Thank you very much for that introduction, and I'm very pleased to be invited by the organisers of the 23rd Bangkok International Symposium on HIV medicine to present on this very interesting and controversial topic. For those of you who don't know me, my name is Mark Boyd. I'm actually one of the early clinical project leaders who worked at HIV-NAT. I worked there from actually the Bangkok Symposium of 2000, which I think might have been the 5th or something. That's when I began work at the Student Syndicate. And I finished the end of 2003. So I spent 4 years at HIV-NAT. And I'm very pleased, very proud of the fact that HIV-NAT has been such a successful clinical research unit, as well as, of course, the Thai Red Cross AIDS Research Society. I'm very pleased and proud to have had a small part in the success of that unit. It's been about 10 years or more since I was asked to present here, so it's nice to be back in the year 2021. I've been asked to present on antiretroviral therapy, weight and metabolic changes. And this is the sort of outline of the talk I want to give. I have about 30 minutes. I've got quite a bit to get through, but I'm hoping I can keep it relatively simple. First, I want to talk actually a little bit about science, and I'll explain who Occam was in a minute. Then I want to talk about the global health problem of overweight and obesity, because this is a problem plaguing the entire world, and particularly countries like mine at the moment, with very little clear way to resolve that. I want to focus mainly on randomised controlled trial data on ART, weight gain and metabolic changes, because there's an enormous amount of data out there. The quality varies considerably, and by preference, randomised controlled data tends to give us more reliable findings. So I'm going to try and focus on that. And in that, I'm going to talk about 3 studies in particular: the pooled randomised control analysis, and the advanced study, and NAMCEL. Then I want to sort of pick through a few other data and insights that I think we can gain about this problem and try and find a simplified explanation. I want to talk about the weight gaining or weight losing capacities of tenofovir in both its disoproxyl fumarate salt as well as its alafenamide salt, in other words, TDF versus TAF. I want to talk a little bit about observations about efavirenz pharmacokinetics and weight change, weight gain after pregnancy in women living with HIV, and also to make the point that a lot of what we're seeing is possibly explained not by the drugs themselves, but by what I would call social determinants, which we tend to forget a lot in our very biomedically focused way of thinking about health and disease. The last thing is to mention a little bit about what metabolic changes and then make some conclusions. So I want to talk with you a little bit about philosophy of science and what science is. The man depicted on the right-hand side of your screens is an approximation of what William of Ockham might have looked like. Notice the different spellings, by the way, of Ockham. William of Ockham was a thinker, a monk and a thinker, as most people were in those days. The people that got to read and think were basically people in the religious orders, because everyone else was just working to stay alive. Ockham is sort of thought about one of the first people who started to think that maybe the explanations for what went on in the world weren't necessarily to do with spirits and gods and phenomena like that, which really dominated the thought of this period, which is, now 800 years ago. He thought maybe there were other explanations that were perhaps a bit simpler from the material world, which was different from the spirit world or the world of God. And an example here, he lends his name, he's most famous in lending his name to a principle known as Occam's razor. And the notion is that if you have 2 explanations for a phenomena, you basically should choose the simpler one, because that's a simple explanation is likely to explain complexity more than a complex explanation will, if you can find a simple explanation. So here's an example on the left-hand side of your screen. Why did the tree fall down? You come out of your house, it's been a windy night, and the tree fell down. So there's 2 possible explanations. There's maybe many explanations, but 2 might be, well, the wind knocked down the tree, And the other one might be, well, there were two meteorites hit the Earth. One hit the tree and knocked it down, and then it hit the other meteorite, therefore obliterating evidence of its existence. That's quite complex. So basically, the notion is the simpler explanation that the wind knocked down the tree, the obvious one you might say, is the one you should choose. And this is a principle we use in science to this day. An elegant, simple explanation generally will trump a complex, messy one. That's an important thing to remember when we talk about how we interpret data, of which there's so much of course, these days. And in this topic, weight gain and antiretrovirals, there's all sorts of data, and some of it gets very hard to understand what's underlying it all. What about overweight obesity as a global public health problem? Well, I think everybody in the audience should certainly be aware of this, perhaps not so much in Thailand, where you don't have such a big problem. But where I live, we have a big problem with overweight and obesity. This is a map actually taken of the 2006 estimates of the prevalence of having a body mass index equal to or greater than 30, which defines people that are obese. And what you can see here is if you look at the darker the colour gets, the more prevalence, the greater prevalence of obesity exists. And what you can see is that when you look at the USA, or you look at Saudi Arabia, interestingly, or you look at somewhere like even Australia and New Zealand, certainly USA, Saudi Arabia are probably more than 40% of people in that society are considered to be obese, that is, have a body mass index greater than 30. And you can see the other blue colours like South Africa, the southern part of Latin America, Chile and Argentina and Uruguay, Canada, Australia, New Zealand. We also are quite big, although perhaps not quite big as the USA. If you look at places like Thailand, for instance, you can see that you're a lot better off if you consider that being obese is predisposes you to all sorts of diseases, not just cardiovascular disease, but all number of illnesses and also premature death by about 4 years. You can see that places like the US are in big trouble. Places like Thailand, India, Southeast Asia in general, except perhaps parts of Malaysia, they're generally only about 10 to 15% of people are obese. So they're much thinner, and that's something that I noticed when I travel to Thailand. When I travel to Thailand, haven't been able to recently, of course, you notice that people are, in general, much trimmer, much leaner, much more healthy looking than they are in Australia, where I see a lot of big people, and sadly I have to include myself in that at the moment. And that's not something which I'm proud. If you look at the US, just focusing on the US, you can see here that all the hot colours is the percentage of obese adults. So again, people with a body mass index greater than 30, you can see that every single state pretty much in the continental USA, not so much Hawaii, but Alaska, yes. Colorado is the only one where the percentage of people in the community are obese is 20 to 25%, still a quarter of people. But nevertheless, some of these places have 30, 35% where everyone's obese. And if you look at this diagram, this shows every single state and the increase in percentage of obese people over the period 1990 to 2018. In a 30-year period, the percentage of people who've become obese in that state, or in all those states, has skyrocketed. So you can see here 30 years ago, most people in every state, the highest was 15% prevalence of obesity. This is actually in Mississippi, this top grey line here, which is a poor and fairly black part of the United States in the south. This is it here. You can see Mississippi beside Louisiana and Alabama. You can see here that 15% of people were obese in 1990, and now nearly 40% are obese. And that degree of change has happened in all these states. Again, Colorado, which is the bottom grey line, only 23% or so people are obese now, but it was like 7 or 8% 30 years ago. So something very dramatic is happening. Everybody in the world is putting on weight, particularly in countries with easy access to food, like the United States. What about in Australia? Well, as I said, I'm a 57-year-old man. I turned 57 last month. And if you look at this graph, then I'm in the 80% of people of my peers who are male, more than 80% are either obese or overweight. And the obese proportion is about half of them, slightly less than half of them. Otherwise, you're overweight. So I'm not, even though I consider myself very overweight, I'm not actually particularly unusual when I walk around in the streets in Australia. There are many people that look like me, and the same with women to a lesser extent. It's also important to remember that there's a socio-economic gradient. So in Australia, we have a lot of people that are more overweight if they happen to have more social disadvantage and have greater social risks. And that particularly includes our Aboriginal population, who are quite overweight in general. They're about 3% of the entire population. And also other people with social disadvantage tend to be bigger. All right, let's get on to the topic at hand. Just keeping those principles in mind and those observations in mind, let's look at some of the randomised control data around weight gain and metabolic changes that's appeared over the last couple of years. The first study I want to look at is, I think, the best and the most revealing, and I highly recommend anyone who's confused about this topic to read this, because I think really pretty much all the truth and all the important observations are contained in this one single study, which is, the lead author is Paul Sachs, who will be familiar to many of you, who's at Brigham and Women's Hospital in Massachusetts and part of the Harvard Medical School. And this is a selection of 9 phase 3 double-blind randomised controlled trials, all of which were run by Gilead Sciences. They did a pooled analysis of these 8 selected RCTs to try and get a better handle with bigger numbers on what's going on with weight in these very controlled studies. You can see these are absolutely gold standard studies in terms of making observations that are fairly likely to be true rather than false, bearing in mind that most things published in medical journals, most of the results are false. The analysis includes over 5,500 people who were infected with HIV, and they were commencing their first therapeutic antiretroviral regimen in a trial. And you can see, sorry, just to go back, most of them were followed for 3 years, some of them were followed for 2 years. Okay, now here's the money slide for that. There's a lot of data. I highly recommend you go to this article, which really has a lot of really useful information and robust analyses, very well thought, very, very good article, high quality, one of the best, I think, of last year. It's in Clinical Infectious Diseases. It was published, I think, in the paper version about September or October of last year, so 2 or 3 months ago. And what this shows you is the pooled analysis of all those randomised controlled trials between 2003 to 2013. And in the first panel here, you can see the mean weight gain over 96 weeks in all studies pooled. And in this first panel, it's divided between, it's stratified between people who had an integrase containing regimen, in the blue a PI, protease inhibitor containing regimen, and in the yellow a non-nucleoside reverse transcriptase regimen, which in those days would have been either nevirapine or efavirenz. And what you can see is that if you look over those 96 weeks, you get quite an acute rise over the first 36 weeks. And that basically accounts for probably the point at which viremia is being suppressed. Nearly everybody will be suppressed by 24, if not 36 weeks. Of course, it's much faster with integrated regimens, but nevertheless with PIs and NNRTIs, we could generally expect everyone to be fully suppressed by week 36, regardless of baseline HIV RNA level. And after that, you see perhaps an inflection. This is return to health. So this is as people get better. Of course, they put on weight because they become far less catabolic. They're not fighting an infection. And after that, there's a gradual weight rise over a period of time in the integrase regimens. And what you don't see, that's in contrast to the degree, there is still, after return to health, some degree of increase in weight, but it's not as profound, both in protease inhibitors and people taking non-nucleoside reverse transcriptase inhibitors. Okay, if we go to the second panel, we're looking at the weight, we're looking now within class. So we're looking at the difference between weight gain over 96 weeks between people with a bictegravir third agent, a dolutegravir third agent, or elvitegravir cobecistat. And once again, what you see is that there's the acute rise to week 36, return to health. And then once that's been established, you see an increasing gradual rise over a period of 96 weeks, which seems, at least in terms of bictegravir, to sort of be plateauing off at that stage. Maybe this is the point at which weight gain stops, or at least moves down to a lower gear, if you like, bearing in mind, and this is important, that after the age of 30, at least in Western populations and people generally continue to put on weight by year. So people will normally put on weight around 0.5 to maybe 1 kilo every year, even if they're regardless of their HIV status. That's across the population. So you need to keep that in mind when you interpret these weight gains, because part of it is just natural increase in weight as we get older. Okay, what's interesting about this, of course, is that the elbictegravir corbicestat arm doesn't gain the same sort of weight, and that's probably explicable on the basis that the corbicestat probably is the boosting agent, a bit like ritonavir. We generally think that's fairly poorly tolerated compared to non-boosted, and therefore people tend to put on less weight because of that adverse effect. Okay, finally, in the last panel, the weight gain across this 5,500 strong pooled population, depending on what was the most active non-3TC, non-XTC part of their backbone nuke combinations. And what you see is, again, a hierarchy. TAF has the most weight gain, followed by abacavir, followed by tenofovir, and then followed by zidovudine. And we all know zidovudine was poorly tolerated with a lot of gastrointestinal adverse events. And not only that, as a T analog, it's been associated with lipoatrophy. So these people were probably having poor intake, less appetite, and not only that, were losing peripheral fat because of the mitochondrial toxicity of zidovudine. They're three incredibly robust and very important, I think, observations that really cut to the chase of what's going on with weight gain. Okay, so just to follow up. So there were also some other observations done, and pre-specified analyses looking at the differences between males and females, difference between black and non-black populations, and then an analysis looking at both those things expressed as either black female, black male, non-black female, non-black male. And what you can see is the same sort of increase, again, a slightly sharp increase over the first 36 weeks and then slight plateau off. Again, this is probably return to health. This has got nothing to do with the drugs. It's got to do with the person. And then black people tended to put on more weight than non-black people. And then please keep a notice on this chart, which shows that there's a hierarchy between black females, and this is not in Africa. This is mainly in the US. These studies were enrolled. Then black males, then non-black males, and then non-black females. So seems to be something about race, and race I would put to you is not a scientific construct, it's a social construct. So it's probably nothing to do with your genes, but it's got something to do with being black, has things around it like poor access to healthcare, discrimination, stigma, and being lower in the socioeconomic chain is probably what explains some of this, but I'll go into that in a bit more detail soon. All right, when in this pooled analysis, they modelled what the factors were that stayed in once you actually constructed a model, looking at the variables that you might expect to be associated with weight gain. What you see is that being immunodeficient, in other words, having a CD4 count of less than 200 at baseline, as opposed to being immunocompetent, and that's over 200, that made up, if you were immunocompetent, you were more likely if you were immunodeficient at less than 200, you put on average 3 kilos more than the people who had a baseline greater than 200. So that's a huge influence. And again, that's not surprising. I think that makes sense in that people who are immunodeficient have probably had the infection for longer. They've been sicker for longer. They may well have even had an opportunistic infection. And they're likely to be quite thin, as of course all of us who can remember treating people before the era of antiretrovirals can remember how thin and wasted our patients were. So it's a huge influence. IV drug use makes sense. You've got about a 1.4 kilo difference, and that makes sense because we know that people who use or have used IV drugs tend to have other problems that tend to interfere with their health. As well as drug use associated problems like viral hepatitis, etc. Being black meant that you were likely to put on a kilo more, and that makes sense. So if you think of those graphs the graph I showed you in the last slide, High viral load, again, it makes about a kilo difference compared to starting with a viral load less than 100,000 copies. If you're symptomatic with HIV, you're more likely to put on weight. Again, that's because if they're symptomatic, they've probably had the infection for longer and have been losing weight while they've been in that catabolic acute inflammatory stage. Females tended to put on a bit more than men. We saw that in the graphs. Age also, people who are less than 50 tended to put on more than 50. And there are some slight differences depending on what your baseline. So if you're obese at baseline versus normal, you are likely to actually put on just a slight bit more weight. Same with overweight and a very normal, as opposed to normal. Pretty minor changes compared to things like being immunodeficient, less than CD4 less than 200 at baseline. Let's look at one of the studies that probably really blew this whole subject apart and really made it a big deal. It was the ADVANCE study. This was a study performed in one site in Johannesburg, which is in South Africa. So bear in mind, this is a study done in a different continent, very different country compared to, say, the US or Australia or countries in Europe, where the pooled analyses were mainly done, which with the SAHMRI study I showed a few slides ago. These are very important observations to begin with, right? These were antiretroviral naive patients, 1,053, and they were randomized 1-to-1 for their first-line regimen to either be what we would call a tripler or tenofovir, FTC, efavirenz. They got the second arm was tenofovir, FTC, and dolutegravir, and the third arm was TAF, 3TC, and dolutegravir. The question being asked here was what was the best combination for patients in low and middle income countries to begin as first line. I won't show you this study is world famous now. It's been gone over many times. So I'm only going to concentrate on the weight. I'm not going to talk about the primary endpoints of viral suppression, etc. But what you can see is when you split for men in this panel and women in this panel, weight gain was fairly profound. Not so much in the men, 5 kilos over 96 weeks, with that, again, that sort of return to health over the first 36 weeks up to 48 and then a bit of a plateau after. Not particularly profound, but there was a difference in weight gain between people taking efavirenz, tenofovir FTC in the green versus dolutegravir with TDF FTC in the blue, and then dolutegravir TAF FTC put on the most in the red. And the same was the case for women, but women put on a lot of weight. So over 96 weeks, there was something like a 10 kilo increase in weight, as opposed to 5 for people with dolutegravir and TDF and 3 for the efavirenz containing regimen. So same pattern, greater weight. And people really got worried about this. I've heard there were even people saying they probably should have stopped the study because this degree of weight gain was disturbing. I certainly wouldn't have thought that, but nevertheless, this really caused a stir and was probably the headline that came out of the meeting, headline news that came out of the meeting at Mexico City at IAS in 2019, about 18 months ago now. Right. Just out of interest, I just popped this one up from this graph up from the pooled analysis, because what you see there is a similar looking grade, right? We haven't got comparators for non-African people here, but for the Africans, what we saw was a pretty profound, in African people in Western countries mainly, in these Gilead studies, but nevertheless African by ethnic origin, if you like. Certainly black women put a lot of more weight on than did white women, and same, not so profound, but again, it was black men put on more weight than white men in those studies. And it sort of reflects, I think it's interesting to reflect the gradient here. There's something familiar there, I would suggest to you, that maybe is giving us some hint about what is underlying this phenomenon. All right, the other study that gives us some control, a comparison about what happens with African people is the NAMSAL study. This one was done in Cameroon, which is a francophone country and is part of the ANRS, French International Clinical Trials Network. Again, randomized open trial. And in this study, they compared as first-line therapy, so again, antiretroviral naive participants who were randomized to either get dolutegravir and TDF, so disoproxil fumarate version of tenofovir and 3TC, versus efavirenz given at the 400 milligram dose, which was proven to be as efficacious as 600 in the Kirby Institute-sponsored ENCORE study. and is now part of guidelines as a possible regimen. So they gave it against this was actually shown to be more tolerable in the randomised controlled trial of Encore. So they compared these two to see which might be the best regimen to give for people naive, to make a distinction between these two. Was there any benefit to dolutegravir, or was this efavirenz, was it good enough? Again, I'm not going to talk about the primary endpoints. I'm going to look at weight. Notice that the weight expressed here is slightly different to how it was expressed in advance. That's just one of the problems, I think, of different people to different things to select. But nevertheless, what you can see is if you look into people that had a greater than 10% change from their baseline weight in the study at week 48, not at week 96, week 48, you can see that the people receiving the dolutegravir, bearing in mind again that they were getting TDF and not TAF as part of their backbone, put on more weight than did people with efavirenz. Okay, and that was the same if you looked at the treatment emergent obesity. So those people that went from a BMI that was less than 30 to a BMI that was greater than or equal to 30, again, you're much more likely for that to happen to you if you're in the dolutegravir-containing arm. All right, so that's the three. I think that's the juice of what I understand is going on in terms of randomised controlled data that holds up to sort of close analysis. But what about some other data and insights that might inform us around that? And the first thing to talk about, I think, is this business of where the TAF is the problem, or where the TDF was the problem in the past, and now we're using TAF. It's not called. It's stopping people from not putting on sufficient weight. And this is really something that still hangs around. It's about, is it TAF? Is it the integrases? What is it? And that's what I mean by this mess about, is there a simple explanation that might explain all this phenomenon, rather than hypothesising that two agents in different classes, so for instance, dolutegravir or bictegravir and TAF are all putting on weight, which to me is jarring and seems highly unlikely because it's a messy explanation, just doesn't make sense. All right. So what's interesting, I think the most interesting observations is that with tenofovir disoproxil fumarate and with TAF, you can actually look at what it does to people who are not HIV infected, which again is a confounder because of the return to health phenomenon. People who are receiving tenofovir as either DF or TAF have been given the drug in large numbers as pre-exposure prophylaxis, of course. And what we saw in the first one, which is IPREX, it's a Bob Grant study that was, I don't know, must be 7 or 8 years old now, published in New England Journal of Medicine. What you saw in that is when people were randomised, and they were to placebo or TAF, so neither the doctor nor the subject knew what they were getting. People who got the placebo put on that sort of expected 1 kilo that I said that most people, at least over the age of 30, put on per year. What was interesting is in the TDF group, they lost weight. So this suggests that TDF actually inhibits weight gain. In fact, it even makes people who are otherwise well, and these people were otherwise fairly well, they're fairly young, sexually active people, they lost weight. If you go to Discover, which was done more recently by, you'll see a similar thing. The people that were randomised, again, this was placebo-controlled, randomised to TDF, lost weight. Admittedly, in this example, only over 24 weeks, but they did lose it. They returned to baseline at about 12 months. But the people who were receiving TAF didn't. They put on quite a bit of weight. They put on slightly more than a kilo and a bit. Again, that's consistent more with no inhibition to weight gain rather than TAF making them terribly fat. This 1 kilo, same as with the placebo here, is about what one would expect in these people. Just looking at HPT and 077, which was, of course, the big news out of the last World AIDS Conference last year, which was virtual, of course, shows that the cabotegravir was again associated with a similar degree of weight that you would expect, weight gain you'd expect. And in fact, in this case, the placebo, which was in fact tenofovir FTC, it was Truvada, also, this is over 18 months, so a little longer, they gained about 1 kilo. And if you look at the tenofovir phenomenon here, you could sort of hypothesize that that's probably what you'd expect if you followed people up for longer than 48 weeks. As I say, this was stopped, but it was stopped after a median follow-up, a person you follow up about 1.5 years. So I think this is really interesting. Tenofovir is associated with weight loss in PrEP studies. The other thing is to look at switch, of course. You could say that switch studies would be the natural studies to do to look for weight gain because, again, you get rid of that phenomenon of return to health and the natural sort of increase of anything from maybe 3 to 5 kilos, depending on where you start and depending on your degree of immunodeficiency, if you're antiretroviral naive. What this shows, this is from Opera, and this was presented, I think, again, by Paddy Malin last year at the World AIDS Conference. What this showed, if you look overall, this is people switching from TDF, a TDF-containing regimen in this part of the panel. At this point, which is marked as 0.0, they switched to TAF. And what you can see, no matter what other drugs you were taking, after you switched to TAF, there was this increase in weight. And again, the question becomes, is that because TAF promotes weight, or is that because they've come off things like TDF and AZT and they've lost that inhibition of the old drug? If you split that out by class of anchor agent, you can see that the people taking integrases and non-nukes had a very similar kind of curve. They gain weight, say, for the first 12 months, and then it tends to plateau. People interested with a boosted protease inhibitor gained a little bit, but then by the end of 48 weeks, actually were sort of almost back to their baseline. All right, what about pharmacokinetics? Can that help us at all? Other disciplines that might shed some light on this confusion. This was an interesting study, I thought, presented again earlier, middle of last year, I should say. I'm recording this on the 6th, so Happy New Year to everyone. This was an interesting study, again, looking in advance. They took 171 of those over 1,000 patients, and they were taking who were taking the efavirenz FTC TDF, so the sort of A-triple arm, the one that put on least weight, as you recall, in the green line. And they stratified the people and their weight gain according to whether they were extensive metabolites. In other words, they were more likely to have a lower level because they had an SMP, a SNP, single nucleotide polymorphism, to give it its full name, or a SNP that would extensively metabolize the drug, intermediates, and then people that were slow to metabolize. And the hypothesis is, and the phenomenon is, the more you metabolize the drug, the lower your level is likely to be, whereas the people who are slow tend to have higher levels. And we know with efavirenz, it's not 100%, but the people with the higher levels tend to have worse adverse experiences and tend to feel worse, particularly the neuropsych phenomena that we're all very familiar with efavirenz, although not so much in my part of the world because we really don't use it anymore. We haven't used it really since we've had integrases. So but it's certainly, none of us can forget the people who had very, very odd and quite disturbing sometimes neuropsychiatric adverse effects from efavirenz. And what you see here is that the people that were extensive metabolizers of efavirenz tended to have the sort of weight change that we saw with the dolutegravir FTC and TDF. They haven't looked at the TAF yet, but they haven't expressed TAF there. But what you can see is that the more likely you were to have a higher efavirenz level and therefore more adverse effects, the more likely you were to not put on weight. In other words, again, maybe the people with higher levels, the slow metabolisms, had more inhibition to putting on weight, i.e. not being nauseous, not having a good appetite, etc. will probably be the main things. That's probably what we're seeing here in this analysis. What about weight gain after pregnancy? This is another thing I think that's very interesting. Again, it came out of last year's, actually this came out of CROI at the beginning of last year. And this was from the IMPACT study, which was a very good study, perhaps a little underreported. And it was a study looking at the use of either dolutegravir 3-TC-TAF versus other regimens, and in particular A-tripler, efavirenz, which is still standard of care, or tends to be. It's changing now, but was the standard of care for women who are pregnant. And what this shows is that, in fact, in terms of the recommended weight gain for women in the second and third trimesters of pregnancy, the dolutegravir FTC and TAF arm, which is in orange, got the closest to actually the recommended weight gain for those women. And it was less so with people taking the TDF with dolutegravir, and again, it was less so with the efavirenz with the TDF. So again, a suggestion there's a hierarchy here, there's something going on. But this didn't actually put on, the problem with this was they didn't put on a lot of weight. The problem is that they put on almost the weight that's recommended, suggesting again that actually this perhaps isn't a bad regimen at all. Perhaps this is a recommended regimen, at least in this population. What about weight and perceptions of weight? So one thing, I think I alluded to this at the beginning of the talk, is that weight is a socially determined, it's a cultural phenomenon. So in the West, we tend to, particularly with women, we tend to idealise women who are normal weight or perhaps even a little underweight, sadly. There's been a lot of criticism of that because of the pressure it puts on women to really try and attain and maintain unreasonable, even unhealthy degrees of weight. And it's always been my feeling that the explanation from Advance was that in Africa, that's different. In Africa, women who are overweight are actually, that's the cultural norm. People like that. Women like that. The men like that. That's not criticised and stigmatised. So I was very pleased to see this analysis that was presented only a few months ago at the Glasgow Drug Therapy Conference. And what this shows is here on the first 4 bars are the weights for baseline and for the 3 arms in men and in women. And what you see is they've compared it to the National Nutrition and Health prevalence data that South Africa have been doing for the last few years. And what you see is that while, let's go to women because that was the most important one. In women, even though the women after week 144, I should say, at that stage, I think the women had put on an extra 5 kilos. So the median was something like 13 kilos. I think when I showed you it was 10. It was like 13, 14 kilos. When you compare them to HIV uninfected women just selected in the community, it's actually very similar to what you'd expect. So the South African women, on average, for this particular age and around this age, is close to being obese. In other words, close to a BMI of 30. It was 29. It was slightly higher in the people receiving the dolutegravir F-TAF, but not greatly so. It was just one point different. So these were nearly obese. These were just obese. And again, when you look down, in fact, the women on the tenofovir, dolutegravir, and the women on the efavirenz tenofovir, TDF, were actually underweight compared to that. So this, I think, is very important to say that it's actually what they're returning to on those people in Advance wasn't becoming, grossly obese. It was actually returning to what other women looked like them in the community, which is what is expected. So this is a terrific, I think, incredibly important study that sort of blows away a lot of the notion that this is some sort of toxicity. This suggests that it's actually people now on a good regimen, which is well tolerated, returning to health and a normal weight according to the people around them. Okay, so let's go back to this advanced thing with advanced study with men and women according to weight. And I'm going to put you to an hypothesis drawn from those last slides that one, people didn't put on weight in the efavirenz arm because it's the least tolerable regimen. Efavirenz is associated with adverse effects that probably inhibit weight gain, as is TDF. The TDF, dolutegravir arm, was the intermediate in terms of weight gain because they still had TDF, right? They didn't have efavirenz, they had dolutegravir, but they had TDF, and that's probably intermediate tolerable. And when you get to the one that had TAF, which is well tolerated and associated with weight gain, even in healthy volunteers, as we've seen on, not healthy volunteers, I'm sorry, people who are HIV negative about to go on PrEP. They had dolutegravir. That is a very tolerable regimen. We've actually got to the point now, I would argue, that we've got such good treatment that these people are now just as prone to getting fat like me and 80% of my peers at my age as people who are HIV negative. I think that's what's going on, and I think that's a simple Occam's razor type explanation which blows away, I think, a lot of the confused and confounded data. So I'm going to use a slide here that came from Andrew Hill, put up a couple of years ago when he talked about drivers of weight gain and loss. He said, and I showed you this, that low CD4 and high viral load, you tend to put on weight. If you're getting dolutegravir or bictegravir, you tend to put on weight. PI as well, I didn't show you that data, but we know that, although not to an extent that you get it with these drugs. Women and black people. And the things that push your weight down are poorly tolerated drugs with known adverse effects, including nausea, which are the drugs of tenofovir and efavirenz. But I think we need to add more to that. I would suggest that we also need to think about the obesogenic environment, the fact that, as I showed you in America, people have managed 40% more people are fatter and obese compared to they were 30 years ago. That's not your genes. That's something going on in our surroundings. And that the parts of that are, could be the theme of an entire conference. Improved ART tolerability. I'm arguing that the reason people put on weight with dolutegravir, FTC and TAF is because we've actually reached the point that we've created drugs that actually are really well tolerated, such to the extent there's no inhibition to them putting on weight and eating normally and normal gut function, etc. The other thing is social norms. So the reason that people in South Africa got so big, and particularly the women, is because their peers are big by our standards, and that's a good thing. They're big and they're healthy. There's all sorts of mythology probably around why they're about sexuality, about fertility. And also you must remember, in places where people have actually starved, putting on weight means you're healthy and you can afford to eat. And that's an important thing in countries like Africa. Also, I should say India, where you see some quite big women. The women who are really big are often well off, and it just shows that they are well off and can afford to eat well. What about metabolic changes? I actually am nearly out of time, and to be honest, I think this metabolic stuff is pretty boring. The first thing is that being obese has all sorts of implications, not just cardiovascular disease. So I think we need to think very carefully about that, including Alzheimer's. It's pretty clear now that the reason we've got so much Alzheimer's disease is because we're overweight. Being overweight does actually have some implications for your life expectancy, so it is important. But really, from the point of view of why people become dyslipidemic and develop metabolic syndrome, whatever you like, is that if you get bigger, that's what happens, and that's really the end of the story. So I think that being sort of obsessed with LDL cholesterol, etc., is really pretty dull. I won't go into I've left some data on the slides, and you can read it in this article about what happened in the pool analysis. You can also look at it online, even with the slideshow from Andrew Hill from Croy last year about what happened in advance. Basically, yes, if you get bigger, you're likely to have dyslipidemia, and some of you will develop insulin resistance, and some of you will even develop diabetes. But I think that's so obvious as to be really, it's the weight that's the issue, not the metabolics. That's secondary. So let me just draw some conclusions. I'm probably over time. I'm sorry about that. I hope you haven't all switched off or gone to sleep. So in summary, I think we should say that weight gain in people living with HIV is very controversial. We understand the early weight gain over the first year, let's say, is expected. But after that, there's confusion and concern about the degree of weight people are putting on. But my interpretation is the increased weight is nothing to do with toxicity. In fact, it's the absolute opposite. It's actually got to do with ART now being so tolerable, and for instance, dolutegravir or bictegravir with TAF and FTC, incredibly tolerable, really no adverse events to speak of, very few, which is a fantastic victory. We should see this as, unfortunately, we should see this as a victory. People are putting on weight because the treatment doesn't affect them anymore. And they're putting on weight like everybody else is putting on weight. That's my feeling. So, look, I mean, everyone puts further research is needed, but the point about the future research needed for this phenomenon is that we need research to tell us how to change that obesogenic environment for everyone, not just for people with HIV, for everyone, because all of us are at risk unless we're really very disciplined, which I know some of you are, many of you are. I'm not. And so in this sense, the research we require is not regarding how particularly to get people to maintain a healthy weight in HIV. It's the same as it is in the general population. All right. So thank you very much for your attention. I hope that at least give you something to think about. Perhaps I'm completely wrong. Very happy to discuss that over email. And I'll leave you this, this final cartoon about Occam's razor. And thank you very much for your attention.